This lecture will go over Chapter 47, the child with hematologic alterations. The diseases we're going to cover include anemia, thalassemia, and hemophilia. I'm going to let you review the A&P slides in the beginning of the chapter on your own, and we're going to get right to anemia. So iron deficiency is the most common cause of anemia during infancy, childhood, and adolescence. Several factors can contribute to iron deficiency anemia, including decreased iron intake, increased iron or blood loss, and periods of increased growth rate. Iron deficiency anemia related to inadequate dietary iron intake is rare before age 4 to 6 months because of the presence of maternal iron stores. Basically, babies before age 4 to 6 months have iron stores that they receive from their mother in utero that they have stored up. Iron deficiency anemia occurs most often in children ages 9 to 24 months as iron stores are depleted. Premature infants can develop iron deficiency early in life because they are born with insufficient maternal iron stores. Delaying cord clamping by 1 to 3 minutes can decrease the risk for iron deficiencies. Decreased iron intake is often related to the intake of large amounts of cow's milk instead of breast milk or fortified formula and iron-fortified foods. The incidence has dropped in recent years because of increased education about and availability of iron-fortified formulas and cereals. The rapid growth of infants and children younger than 2 years, if combined with decreased iron intake, further contributes to the increased incidence of this age group. Adolescents are also at risk for iron deficiency anemia because they too are undergoing increased growth and often have poor dietary habits. The situation is further complicated by the blood loss during menstruation in young women. Clinical manifestations of iron deficiency anemia vary with the degree of anemia, but can include extreme pallor with porcelain-like skin, pale mucous membranes and conjunctiva, tachycardia, tachypnea, lethargy, fatigue, and irritability. Children with lead poisoning often have associated iron deficiency anemia. Consequences of undetected iron deficiency anemia are associated neurodevelopmental issues such as lower IQ and poor executive functioning. Any child with anemia should first have a complete history taken with particular emphasis on assessment of nutritional intake. The results of a CBC in individuals with iron deficiency anemia will show low hemoglobin levels and microcytic hypochromic red blood cells. The total iron binding capacity is usually elevated as the result of decreased serum iron levels. Under therapeutic management, therapy is directed toward increasing the dietary intake of iron and iron supplements. The absorption of iron from dietary iron-rich foods is unreliable and does not rapidly provide the body with enough iron to correct an iron deficiency. Therefore, affected children are given daily oral iron preparation of one of the available ferrous salts based on the content of elemental iron in 3 equal divided doses. Iron supplements should be given on an empty stomach 1 to 2 hours before or after meals with vitamin C rich fluids for ideal absorption. Nurses should educate parents about common side effects of iron administration such as staining of teeth, dark stools, and constipation. Page 1121 has some boxes about iron deficiency anemia that I want you to look at on your own. The pathophysiology of iron deficiency anemia, and then below it, the purple home care of the child with an iron deficiency anemia. So please look at those on your own. There's also a purple nursing care plan for the child with iron deficiency anemia on page 1122 for your review. The thalassemias are a group of inherited disorders characterized by an abnormality in hemoglobin synthesis, resulting in a reduction in or absence of one of the chains composing normal hemoglobin. This impairs the erythrocyte's ability to carry oxygen. Thalassemia major is also known as beta thalassemia and is the most common form. Inheritance is through autosomal recessive pattern. The child who inherits only one gene for beta thalassemia may only have a mild anemia, while the child who inherits two genes will have severe anemia, hence the term thalassemia major. The clinical manifestations of beta thalassemia include pallor, growth retardation, puberty delay, severe anemia, enlarged forehead, frontal and parietal bosing, severe maxillary hyperplasia, and malocclusion. Hepatosplenomegaly and a bronze skin tone can also be seen. Diagnostics include laboratory testing. The CBC will often reflect microcytic hypochromic erythrocytes. Therapeutic management of beta thalassemia centers on three techniques: erythrocyte transfusions, chelation therapy, and splenectomy. So with beta thalassemia, the erythrocytes that are produced have faulty hemoglobin, and those erythrocytes are hemolyzed as they're produced. Because the body's natural response to reduction in circulating hemoglobin is to produce more erythrocytes, bone marrow starts to begin massive production. Progressive disease continues to stimulate the bone marrow to make more red blood cells. The body perceives this as an inability to keep up for the need of erythrocytes, and as a result, sites outside of the bone marrow start producing erythrocytes. The result is a chronic state of production and destruction of erythrocytes that have an inadequate amount of hemoglobin, of normal hemoglobin. Iron is necessary for the production of hemoglobin, and it is a byproduct of the hemolysis of red blood cells. Normally, intestines absorb small amounts of iron. However, with this disorder, the body increases absorption of iron. When increased iron absorption is combined with the increased iron introduced into circulation by transfusions necessary to treat the thalassemia, hemosiderosis occurs, usually in the second decade of life. Hemosiderosis is a deposition of excess amounts of iron into tissue. The result of excessive erythropoiesis and hemolysis is considerable. The bones become thin and fragile from excessive erythropoiesis. Hepatosplenomegaly occurs as a result of the extramedullary erythropoiesis and hemosiderosis. Growth is impaired and puberty is delayed. Without proper management, multi-system organ dysfunction ensues. The major complication of long-term transfusion therapy is hemosiderosis. To prevent organ damage from excessive iron load, these children must receive some form of chelation therapy. So chelation therapy is therapy that removes iron from the body. The mainstay of chelation therapy is the drug deferoxamine. It is most effective when given sub-Q or IV. Splenectomy may be indicated in children who are not transfusion dependent to increase their hemoglobin level and avoid transfusions. Splenectomy is a therapy that should not be considered casually because of susceptibility to infection. Standard therapy for asplenic individuals include immunizations, prophylactic penicillin, and a high index of suspicion or aggressive antibiotic therapy for febrile illnesses as described previously for children with sickle cell. So don't worry about that, but just know that if they're having a high fever with an illness, they'll be on antibiotics. You have a purple nursing care box for the child with beta thalassemia that I want you to look over on your own. The final condition we're going to talk about from chapter 47 is hemophilia. It starts on 1129. Hemophilia is a lifelong hereditary blood disorder with no cure. There's many different factors in the blood that contribute to clotting. And when these factors are missing or defective, blood does not clot as it should. This impaired clotting puts the patient at risk for bleeding and hemorrhage. Hemophilia is an X-linked autosomal recessive disorder. The disease severity is individual but tends to be familial. Bleeding occurs after surgery or serious trauma in all children with the disease. Bleeding occurs after tissue trauma in children with moderate and severe disease. Bleeding occurs spontaneously and for no apparent reason in children with severe disease. Affected children bruise easily, have episodes of epistaxis, and have some hematuria. They can also have bleeding with loss of deciduous teeth, even from minor lacerations and from injections. Most commonly, bleeding develops in the muscles and joints, especially the knees, in those children with moderate and severe disease. Recurrent bleeding commonly occurs in the same joint in severely affected children, causing swelling, pain, bleeding, and stiffness. Hemophilia is sometimes, but not always, diagnosed after circumcision. Because the most common sites of bleeding are in the muscles and joints, the diagnosis can be delayed until toddler years, when children become more active and the disease has an opportunity to manifest itself. By the preschool years, most affected children have had an episode of persistent bleeding from a minor traumatic laceration. A diagnostic workup would include monitoring labs that monitor bleed times and coagulation studies. The management of hemophilia is highly individual and depends on the severity of the illness. Therapy aims to prevent excessive bleeding and tissue damage by supplying the body with additional factor, substituting for factor that is missing or ineffective. Prophylactic therapy is now being started in infants and young children with severe hemophilia to prevent joint problems. Some children with mild hemophilia A can use desmopressin, which has a vasoconstrictive action to stop bleeding. Children with hemophilia A or B can be given aminocaproic acid, an oral medication that stabilizes oral clots and can also sometimes stop nosebleeds. We have a yellow box on 1132 that reminds you to teach parents and caregivers not to give the child aspirin, which affects platelet aggregation, because that can increase the risk for bleeding. In addition to factor prophylaxis, the child with hemophilia must try to avoid activities that induce bleeding. Special precautions can be taken to protect joints, thereby allowing the child to lead a more normal life. Prophylactic factor replacement therapy should also be given before surgery and some dental procedures. Bleeding is treated with rest, ice, elevation of the affected part, and compression, often denoted as RICE. Most recent data suggests that low temperature impairs platelet function, so cold should be applied for no more than 15 to 20 minutes at a time. Subjective data gathered from a child known to have hemophilia should include information about recent trauma and initial measures to stop bleeding. An important question is the length of time that pressure had been applied before the bleeding subsided. Other questions to ask include whether the swelling increased after the surface bleeding stopped, and whether swelling or stiffness occurred without apparent trauma. Hemophilia has a purple nursing care box that starts on 1131 that I'd like you to review on your own.